today's meeting. And without further delay, we're going to go ahead and get started. It's a pleasure to introduce Dr. Chebib, who's assistant professor at the Mayo, who's going to be telling us about biomarkers for individualized ADPKD progress for predictions and precision analysis. So I'm going to turn it over to you, Dr. Chebib. As soon as you're ready, you've got the floor.
Thank you very much, Dr. Schroeder, and thank you for your invitation. So I was invited kind of a little bit last minute. So since it was on imaging and with Dr. Klein, I thought we'll stay within the same theme. And we've been collaborating with him, of course, on many of the things we're going to be showing. So thank you for the invitation again. And would like to kind of share a little bit my view on how can we get a precise prognosis, which would be very helpful in clinical practice, but also in clinical trials too. Here are my disclosures, nothing related to the stock. So I will go over a few biomarkers. What are the types of biomarkers? Then we'll show kind of what's the current state in our clinical practice, and then recognizing some novel imaging that we've been working on, as well as other groups, and maybe discuss if there's time some collaborative efforts in terms of how can we move the field forward in this regard. There is no need for introduction for this group on ADPKD, but I'd like to always show that ADPKD is really a devastating disease. It's a relentless disease that leads to kidney failure in a lot of patients. Almost all male patients would reach kidney failure at some point. Definitely the majority of the patients would reach kidney failure in their peak of their productivity, affecting their quality of life as well as the life of people around them. So definitely there's a lot of need to slow this disease progress, and thank you everyone who's working on in this field to understand this disease better in all aspects, so we can make really a difference for these patients. Another thing I'd like always to show is that not all cystic diseases are ADPKD. So now that we have new treatments, treatments, we need to have accurate diagnosis. So all of these patients are kind of anecdotal examples in our clinic that came in as a diagnosis of PKD, but in fact they're not. So for example, this patient who's 50 years old with very low GFR as compared to their cystic burden had actually tuberous sclerosis, and after getting brain imaging and genetic testing, this was confirmed. This patient has OFD1 syndrome, which is great mimicker for ADPKD in female patients with typically no family history. The third most common PKD gene is now a monoallelic IFT140, and we see this actually quite frequently. And this could have been misdiagnosed as ADPKD. And if this patient goes into clinical trial, which is less likely now with inclusion criteria that are put in place, but if they go into clinical trials, probably we're not going to see a good result. Hence the importance of accurate diagnosis. And then this patient also has extensive family history. They've always been called to have PKD, but as you can tell from the imaging, that this GFR is not congruent with the cystic burden. So 68-year-old with 25 of GFR, they have gout, family history of gout at early onset. So hence the importance of genetic testing, that I advocate that it should become a part of the clinical practice and not just in research. So definitely there's a genetic spectrum of cystic diseases. In addition to PKD1, PKD2, we've talked about the monoallelic IFT140. Definitely there's kind of a spectrum and overlap between ADPLD genes, the GANAB gene, the DNAJB11, which kind of an intersection between having kidney cyst, liver cyst, but also significant interstitial fibrosis, similar to autosomal dominant tubular interstitial kidney disease with MUC1, UMOD, and HNF1 beta. Other ciliopathies, which are childhood diseases, and ARPKD as well. So always good to keep that in mind. And Now that genetic testing is becoming readily available, I think we should not shy away from really characterizing our patients very, very well. And so having ADPKD, which is going to be the most common case seen in clinic, not all ADPKD are kind of created equally. There's such a high phenotypic variability that's very striking. Despite, for example, in this case here in C, patient, a female 34 who has a PKD1 truncating mutation versus another patient, similar age, 36, male with PKD1 truncating mutation as well, but you can see a huge difference in their phenotype. This patient has a preserved GFR, smaller total kidney volume, versus this patient has a significant disease with very high TKV and low GFR already at age 36. So how can we really distinguish and how can we objectively identify these patients on top of just having a GFR? Furthermore, with even within the same family, inheriting the same variant, a pathogenic variant, there's going to be a good interfamiliar variability showing and emphasizing the complex interaction beyond the inheritance. So many groups have shown this, as well as ours. We've shown that in, for example, this family with pedigree one of their family members reached kidney failure at 38 versus another family member at 68. So there's a big variability on average, maybe in PKD1 truncating in our cohort, a smaller cohort, 14 years of age as a mean average between their ESRD onset, the age of onset. Then having a family history, a lot of times I hear patients that they kind of predict their own outcome based on their own family history, and they tell me, okay, my parent or my grandparent reached kidney failure at age less than 55, so this is going to be similar to what I'm going to do, which could be true, but it might not be true as well. But having family history is kind of one predictive marker. If one of the family members reached kidney failure before 55, it's predicted that they have PKD1 mutation, versus if they have one family member reaching kidney failure above 70, perhaps it's a PKD2 mutation. But again, we need definitely more accuracy and not just a group accuracy. We need an individualized prognosis and accuracy. A lot of factors go into play into the phenotype of ADPKD in addition to the inherited pathogenic variant. There's a lot of modifiers that hopefully we can identify some of them, but it's definitely more complex than we're thinking. There's a lot of epigenetic factors and changes, environmental factors that we emphasize on for patients, such as the high BMI, high caloric intake, high salt intake, and low fluid intake that lead to these pathogenic mechanisms, increasing the cyst number, growth, elevated vasopressin, leading to all these different mechanisms and signaling pathways that are abnormal in ADPKD. And then to assess the severity of the disease, looking at the cystic burden as well as the renal function is now the current state, but I think we need to go beyond that, hopefully. In addition to total kidney volume, age-adjusted kidney volume, which is the Mayo Imaging class, we should go into the cyst number, other cystic characteristics that we will show, texture, other markers in imaging, as well as the clinical and genetic biomarkers and the pro-PKD score, and hopefully more urinary biomarkers as well. So again, how can we assess the difference between these two patients? So both of them have ADPKD, very young, 27, GFR around 90. And as, of course, you can tell that patient A is not going to do very well versus patient B is going to do much, much better. So it's not enough to say, okay, come back in a few years and let's see what we can do for you. We need to give them accurate information and then try to modify their trajectory. So what kind of biomarkers can help us predict the future GFR, age of onset of ESRD, and response to therapy? This patient, based on the Mayo Imaging classification and calculator, would reach kidney failure in 13 years versus this patient in 43 years. So biomarkers are defined as kind of different categories. Prognostic biomarkers are used to identify likelihood of clinical event or progression. of a disease, such as total kidney volume, height-adjusted and age-adjusted total kidney volume, the eGFR slope, pro-PKD score involving genetics and clinical factors, copeptin, and the urine to plasma urea ratio. Those are examples of possible prognostic biomarkers. Then predictive biomarkers are used to identify those who are more likely to respond to an intervention. So also Mayo Imaging class, kind of identifying risk of rapid progression between Mayo class 1C, 1D, 1E. Other imaging characteristics, the pro-PKD score, which also has a predictive value, as well as starting with lower GFR. Then response biomarkers are really an interesting topic, and hopefully we can get more of these to help us understand if we give a treatment, are we really helping the patient, and can we in real time know if the patient is getting the right response and maybe titrate up and down the treatment. So right now, a good example is urine osmolality and using it in tolvaptan titration, but also hopefully in the future, urinary PC1, PC2, and maybe others. So again, with the clinical natural history of ADPKD, it's not enough just to go by the renal function, since it's mostly preserved for a few decades early on. So total kidney volume is well established as a prognostic biomarker. And then later on, we'd like to use the combination of GFR rate of decline and TKV. But again, hopefully we'll get more than that. But this is the current state that we use in practice. Of course, CRISP, as you all know, is one of the biggest landmark studies in PKD and still following many of these patients and giving us a lot of insight on the natural history and the prognosis and predictions in ADPKD. And this has shown that higher TKV rate of growth is associated with faster GFR rate of decline. Then in the second iteration of CRISP, after a follow-up of 8 years, at baseline, if height-adjusted TKV is for every increase of height-adjusted TKV at baseline of 100 ml per minute, there's an odds ratio of 1.48 to reach CKD3 in 8 years. And with a baseline of 600 or above, there's definitely higher chances of reaching CKD stage 3. So height-adjusted TKV has been was better predicted than baseline age, serum creatinine, BUN, urinary albumin, and MCP1. So with that, total kidney volume has been actually one of the first approved prognostic biomarkers by the FDA. So this is a good achievement for nephrology in general. And right now, it's considered a reasonably likely surrogate endpoint in clinical trials. The gold standard is to go by planimetry. We don't use stereology anymore. And then we can use ellipsoid equation for estimation. And with the advances of technology, we can use artificial intelligence to give us within a few minutes or seconds the actual numbers, instead of having an imaging analyst to go through the images and spend about an hour on each case. And we have implemented this in our practice. So now when I order TKV, when I order an MRI, and hopefully in the future CT scans as well, we can order an EPIC total kidney volume, and it goes from the order, it goes to the radiologist, then the technologists, they verify and quality control, then it comes back to the radiologist, and all this doesn't take much time. So it comes back and it's added to the final report in the radiology with good accuracy as well. So we're happy with this improvement and implementing this in the clinical practice. Why is this important to obtain TKV? So Mayo Imaging classification is a good pragmatic way to prognosticate patients. By having only one total kidney volume, you can predict future GFR. So Mayo Imaging classification goes by identifying patients who are typical versus atypical. So class 1 are the typical patients who have bilateral and diffuse distribution, mild, moderate, or severe replacement of kidney tissue by cysts, and all the cysts contribute similarly to TKV. And then having adjusting one TKV to age will give you kind of predict the intrinsic TKV rate of growth. And for Mayo Imaging 1, we predict, or we kind of classified Mayo Imaging class 1C, 1D, 1E as patients who are at risk of rapidly progressive disease. And then through CRISP-3, this has shown very nicely that each age group and per Mayo Imaging class, they would have a different GFR rate of decline. So annual rate of decline would be, on average for Mayo Imaging class 1E, 4.5 or above. But as you can see here, with younger age, it's a little bit lower. Then at older age, it's a little bit higher. So patients with Mayo class 1E, you would see a GFR rate of decline a little bit early on. And then class 1D, 1C is a little bit slower than that. And then 1A, typically they don't reach kidney failure. So on average, patients with Mayo class 1E reach kidney failure at age 40, 1D at age 52, and 1C at age 54. And then you can use the Mayo Imaging calculator by using the ellipsoid equation, so you don't need a fancy imaging analyst and software to obtain TKV. So that has been a good practical way of obtaining TKV by entering all the various measures, getting the TKV, adjusting to age and height, and then obtaining actual total kidney volume and the Mayo Imaging class. Then using the Urazabal equation and the current GFR, then we can predict in how many years the GFR is going to be closer to 10 ml per minute, and that would give us when the patient's going to reach kidney failure. So this is kind of the actual way of doing it right now, but we tell the patients that this is not a perfect prediction, and we hope in the future to get a little bit better predictions and with more accuracy. All right, so and then, as you know, Tempo 3.4 has shown an effect between tolvaptan on TKV as well as reduction in GFR rate of decline, but many other agents have not. So with bosutinib, for example, there was a significant effect on TKV reduction, but no effect on GFR. Same for octreotide, lanreotide, and the HALT study. So why is that? So that's kind of something that intrigued me. So right now, if we're looking at a treatment and we're looking at the GFR slope, that would be kind of the endpoint that would help us get a traditional approval. We're using TKV as a reasonably likely surrogate endpoint, but a treatment can help reduce TKV rate of growth, as well as reducing GFR slope of decline by two different mechanisms. And then possibly by reducing the growth of the total kidney volume, also you're helping with the GFR rate of growth as well, rate of decline. However, there might be a situation where the treatment is only helping the GFR slope through the cystic, by reducing the cystic burden and the cystic growth. But also there's a third scenario where the treatment is helping both GFR and TKV in two different independent mechanisms. However, there's other factors that have affected GFR either positively or negatively, as well as other factors affecting independently TKV slope. So it's kind of a complex situation here. So with traditional approval and endpoint, FDA has assigned a GFR change of more than 30% changing in the decline of the rate of decline of GFR will help us get a traditional approval. So hopefully by doing kind of a good inclusion criteria, you'll be able to pick the rapid progressors so you can reach these events within a reasonable time and the time of the clinical trial. So it's important, again, to identify who are slow versus rapid progressors. So that's where the whole point is. Then also you can get approval by using TKV rate of growth, and then as an accelerated approval. So we proposed a strategy for patient selection when using GFR as an endpoint, and instead of just using GFR versus Mayo Imaging class, is to use a combination of Mayo Imaging classification, the age at inclusion, as well as the GFR. And then we proposed, based on the predicted GFR rate of decline, the natural history of the GFR rate of decline based on the age groups, the Mayo Imaging class. We propose the strategy to use to include patients who are age 18 to 42, between GFR 25 to 90. Then for class 1D, 30 to 45 years of age, that's when their GFR is going to be between 25 to 90. And then Mayo Imaging class 1C, this age group between 40 to 59, and then with GFR of 25 to 65, and same here for Mayo class 1B. So by using this, you'll be able to show within 2 years of period of time, so within a reasonable period of time, you'll be able to show an effect on the GFR slope, because as a natural history, you'll be able to see that in the standard of care. Alrighty, so in addition to all this, can we add other biomarkers to really help us identify high-risk patients and response to treatment? So we talked about TKV and Mayo Imaging classification. There's a lot of potentially other biomarkers that could help us improve this predictive modeling. And by having an accurate prognosis, this is better for patient care because we can tell patients how they can adjust their life based on estimated age of onset of ESRD. The clinical trials will probably have higher chance to succeed and have less failure of promising treatments. But for that, we need definitely a lot of a large collaboration between biobanks, repositories who have characterized patients with long-term follow-up. So let's talk about what other biomarkers can we add. So imaging texture has been proposed by Tim Klein and his group at Mayo Clinic, Rochester. And texture is the appearance and the structure and the arrangement of different intensities that could be seen in any image. So in an MRI, you can extract a lot of these biomarkers and a lot of the texture and the texture analysis of these by picking up on the entropy, energy, and the various items that could be extracted from an MRI. So in a way, it can tell us if there's more fibrosis, there's more inflammation, fibrosis type of thing that couldn't be picked by just TKV and cystic burden. So definitely a powerful way of trying to improve the prediction of GFR rate of decline. So if you add it to age, GFR, height-adjusted TKV, and other traditional biomarkers, texture on its own, and by adding texture to all those, it does help improve the predictions to reach CKD 3A, 3B, or 30% change in GFR. So definitely texture improves our predictions. By taking just TKV versus TKV plus H plus eGFR, and then adding texture to all this, definitely we improve the predictions of GFR rate of decline. But this has been going on for a few years now, and we couldn't get it to practice yet due to the complexity. So this where also biomarkers have to be practical and able to achieve that in various clinical settings. So hopefully by getting also additional advances in imaging and in technology, we're hoping to be able to provide this to a larger group of patients as well as cohorts. And by that, I mean, if we're trying to establish an infrastructure, what we call the PKD interface or platform, where you can upload your images and you can get these biomarkers back. So hopefully with that, we can try to translate these great findings and add it to TKV as well as other biomarkers. And again, as mentioned, not all ADPKD are created equally. So in terms of what biomarkers could be extracted additionally from imaging, definitely there's more than just TKV. We talked about texture, but also if you look at these images, as you can tell, not all of these patients have the same prognosis. So this patient here, 36-year-old PKD1 truncating, definitely has the worst prognosis. This is very typical, very big TKV, probably Mayo Imaging class 1E. But this patient also here above 43-year-old with the same TKV as well. But you can tell that they have preserved renal parenchyma, and the TKV is only because of several few very large kidney cysts. Same here for this patient versus this patient. So not all TKVs are the same, and we shouldn't kind of take TKV just blindly. So in addition to looking at the images, hopefully now we can, in an objective way, say, this patient, despite having Mayo Class 1E, they're going to do much better than this patient because of the imaging parameters that I'm going to show you. So this was only possible through advances, again, with Tim Klein and his group, being able to obtain instances segmentation. And by that, I mean we can obtain cyst number, cyst surface area, and many other parameters by using artificial intelligence. So these cases usually take 2 to 3 days by an imaging analyst, but by banking and using the technology, now we can obtain these parameters within reasonable amount of time. So we can obtain, in addition to TKV, total cyst volume, total cyst number, percent of cyst index, kidney surface area, cyst surface area. So not only the kidney surface area, but the cyst surface area that's touching the parenchyma, the cyst parenchymal surface area. That's the surface area that's just touching the parenchyma. Here, the cyst surface area is the whole cyst area. So that helps us exclude the exophytic cyst as well. The total parenchymal volume, so the parenchymal volume, then clustering coefficient network, and then through that we can obtain all these parameters. And Adriana, as well as Tim, have shown the utility of these new image-derived biomarkers, looking at the CRISP cohort. And they showed that, again, with these same examples, that this patient here that I'm focusing on, if you use just TKV, they're going to be, you're not going to be able to predict well their GFR rate of decline. However, and then same for total cyst volume, total cyst number, it's a little bit better for this particular patient. And then cyst parenchymal surface area is definitely better prediction for their GFR of decline. And you know that their GFR is not going to decline much for these patients. And here, by adding all these parameters, in addition to TKV, age, by adding total cyst number and cyst parenchymal surface area, you'll be able to move this patient from predicting that they're going to decline their GFR significantly to predicting that they're going to do much better, and that's what has been observed. So again, adding total cyst number and cyst parenchymal surface area has improved the prediction of the 8-year and 20-year period compared to just HtTKV alone. And we looked at a number of patients who've reached kidney failure. So all these patients have reached kidney failure with ADPKD. And you can see here the Mayo Imaging Class 1E have reached kidney failure earlier, of course, than 1D and 1C. But you see there's a big spread of these patients reaching kidney failure in a spectrum, and it's not, and there's a large spread of these patients in terms of age of decline. We looked at these patients and we found that a lot of these patients who reach kidney failure at older age, they have more macrovascular disease as compared to the younger patients. And then in terms of TKV at ESRD, we found that there's a decline per decade. So patients reach TKV, reach end stage, but they don't have similar TKV at end stage. We think that there's an aging and vascular process towards kind of mid-age to older age where it starts to add as a factor leading to kidney failure, in addition to their cystic burden. And we looked at those advanced imaging biomarkers at kidney failure in ADPKD. We had a smaller number of patients with MRI at time of ESRD. And then we divided them into 3 tertiles, less than 46 years of age, 46 to 56, and above 56. And then we looked at all these imaging, advanced imaging biomarkers in terms of cyst number at ESRD, cyst surface area, cyst parenchymal surface area, total cyst volume, total parenchymal volume, cystic index, and parenchymal index. And we found that at time of ESRD, total parenchymal volume is much smaller in patients who reach kidney failure at older age. So there's more kind of fibrosis also as well. And then we looked at the cystic index, and in my mind, if you reach a certain threshold of cystic index, you reach kidney failure with PKD. And we found that there's kind of a similar comparable cystic index across patients with age groups, as well as Mayo Imaging classification at time of ESRD. So although the numbers are small, we still need definitely a lot of larger group to be able to make more final conclusions, but this is worthy to note that cystic index was comparable at ESRD. Now, also this has been looked at as well, the cyst fraction as a biomarker in ADPKD. So with Dr. Mueller's group, they've looked at the cyst fraction, and they showed that TKV predicted GFR rate of decline, but also cystic index had a better prediction of eGFR rate of decline. So cystic index is potentially a good biomarker in ADPKD and maybe additive to TKV as well. And again, we shouldn't just take one biomarker and just apply it. I think there's a need to include multiple biomarkers together. So we shouldn't just focus on imaging and forget genetics or vice versa or other biomarkers. The Achilles heels of genetic testing was it's not available, it's hard to get, but now that it's available and it's easy to get, we should start looking into better characterization of these patients. So with the PKD score, which has good prediction if patients reach kidney failure, to reach kidney failure less than age 60, if they have a PKD score of 7, 8, or 9. And this is based on being male, having hypertension less than 35, or any cyst bleeding or infection less than 35. Also PKD1 non-truncating versus truncating would get additional points. PKD score also predicted response to tolvaptan. So with patients with intermediate risk versus high risk, there has been a good prediction that they would respond to tolvaptan, versus patients who had a PKD score of 3 or less. They didn't respond. They didn't show improvement with tolvaptan. So this is also a way of predicting response to tolvaptan. So in the following maybe 5 to 8 minutes, I'll show a few other biomarkers. So plasma copeptin has been shown to predict disease progression in ADPKD. So patients with baseline copeptin, with higher baseline copeptin, it predicted kidney growth and eGFR of decline over 3 years. So here in quartiles, so if patient had higher copeptin at baseline, they had a higher annual change or TKV rate of growth. Same here with eGFR rate of decline was higher with those who had higher copeptin, independent of sex, age, baseline GFR. But then when TKV was added, that association was lost. Also, copeptin increased after 3 weeks of taking tolvaptan. And then for patients who had higher baseline copeptin, they had larger effect of tolvaptan on TKV growth and eGFR decline. So if a patient started with higher copeptin, they responded better to tolvaptan. Then also, as we mentioned, the copeptin increases from baseline. And then if you had higher increase, so larger percentage of increase within 3 weeks of treatment, also these patients showed better disease outcome with lower TKV growth and lower eGFR rate of decline. So copeptin could be used in this setting as well. Then also so copeptin is not easy to get for us. For example, we have to send it to Mayo Rochester to get it. We're doing this in a clinical trials setting, but we don't use it clinically. However, bicarbonate is used on a routine basis. So here it's a very nice study from DPAC trial and consortium from Netherlands and with Dr. Ron Gansevoort's group, who showed that even having, they divided bicarbonate into 3 tertiles, so on average 23 versus 26 versus 29, and then trying to predict more than 30% eGFR loss or kidney failure. And they showed that patients with the lowest tertile of bicarbonate. So with lowest versus highest bicarb tertiary, there's a hazard ratio of 2.95 in eGFR decline. And then for every 1 millimole per liter decrease in bicarbonate, there's 25% eGFR decline per 1 millimole per liter or 1 milliequivalent per liter. So quite significant here, even despite having even a normal bicarbonate. So this is something that we could add as a multi-score to predict PKD progression. Urine plasma urea ratio also has been shown by the Gansevoort group, and then the lower the urine to plasma urea ratio, the worse the worse the outcome. So in terms of starting kidney replacement treatment versus reaching GFR less than 15 or GFR decrease above 40%, the hazard ratio for the tertiary with the lowest ratio was 13.1, so quite significant as well. So those biomarkers probably could be standardized and could be obtained easily. Other biomarkers that are harder to implement are the beta-2 microglobulin and MCP1. So they need better standardization as they could be quite different between one lab to the other. But also this has shown that adding urinary biomarker to Mayo Imaging class or pro-PKD, it improves prediction of who is rapidly progressive, who has rapid progressive disease in ADPKD. And here they used adding up urinary biomarker scores if the patient had, depending on their quartiles or tertiles, they added up these scores. So this is showing kind of the utility of each of these biomarkers. But I think the key is how can we as a group add all these biomarkers together? How can we add these repositories of clinical patients that are well characterized by imaging, genetics, and characterized by other biomarkers? How can we implement all these different biomarkers together, validate each other cohorts, so we can have higher numbers instead of just having 500 to 1,000 patients, have many more patients, so we can get good results. I'll skip through this a little bit quick since we're running out of time, but we've shown also that urinary pyuria, so if you have sterile pyuria, just white cells without infection, patients who've had that, they've reached kidney failure 4 years on average earlier than patients without pyuria. So we've looked at around 350 patients in each group. So this was interesting, possibly being explained by inflammation. And we've shown that after identifying pyuria, the eGFR rate of decline has progressed from negative 2.3 ml per minute per year to negative 3.8 ml per minute per year without a change in annual TKV rate of growth. So possibly intrinsic factors of inflammation and fibrosis also are an important factor in the decline in eGFR and reaching kidney failure. And then lastly, also there's a lot of work on metabolic biomarkers. This is one example from TAME PKD trial. And also another example on how can we implement these metabolomics and metabolic biomarkers, whether urinary or serum, into the equation of prognostic, of predictive modeling. And then lastly, would like to kind of propose collaboration with anyone who's interested. Would like to create a biorepository of urine samples, blood samples, imaging, as well as genetic samples into a digital and clinical biorepository, and then also using AI and machine learning to kind of create a large cohort where we can predict future GFR with much better accuracy, as well as potentially response to various treatments in clinical trial or in clinical practice as well. One portion of this is now almost done here at Mayo Clinic, Florida, which is the digital biorepository. We have now a way where you can upload your images and then get back a lot of the imaging biomarkers. It's still under piloting, so if you're interested, please reach out to me, and hopefully we can help with we can collaborate and try to to advance this field together. So in summary, TKV and H-index TKV with Mayo Imaging classification continue to perform the best as a solo biomarkers. There's a lot of data that could be extracted from abdominal imaging, and then multiple prognostic factors have been identified, and hopefully we can have a multi-score where we can improve prediction, and that would improve individualizing the prognosis, improving the success rate of clinical trials, and getting more treatment translated from bench to bedside. And with that, I thank you for your attention.
Thank you, Dr. Chebib. This is now open for discussion. If you don't mind, raise your hand and we'll call on you. I'll just get things started here. All these biomarkers that you put out and presented here today, I mean, there's a ton of those. Do you have, or do you think soon you will have a recommendation of which ones are the most effective that we should be using that would show a difference in the shortest amount of time?
Great question. So there's work with collaboration between CRISP and CRISP investigators. So there's a lot of nice predictions there. So keep an eye at the ASN. There's going to be a poster with Dr. Alan Yu. And then there's going to be multiple factors that could predict a little bit better on top of the TKV. So I think a combination of all of these, it has to strike a good balance between having good validation from other cohorts, but also the biomarker should be easily obtained in various clinical settings and well standardized. So like having a serum bicarbonate is well standardized versus urinary MCP1. It's not going to be easy, and the metabolomics are probably kind of very difficult, but could be standardized at some point. The imaging, for me, the imaging, if you can extract, that's the most objective way because you have the image there. If you have the MRI, or hopefully in the future also CT scans, but MRI, you can extract all this imaging just from one image, one set of images. You can extract a lot of the data. That's probably the best way to start there, and then add few serum biomarkers that are easily obtained in clinical practice and start from there. BMI, probably I didn't put obesity, and then the central obesity we can also extract from the images. Those are objective way of extracting data, and just by automating these things with AI and machine learning, you can definitely get accuracy and standardization, good standardization.
Thank you. Sarit?
Hi, thanks for this excellent presentation and let us join. Few questions. One is with respect to the repository and the imaging data, etc. Are you also getting or trying to get it's not just imaging, you can do more, obviously, with many patients go for transplant, just like myself, with bilateral nephrectomy, and oftentimes you can get the kidneys out in a hole. And even if you have to kind of squash them to get them out, you still have a lot of data out of it, both in a sense of imaging slices versus actually doing tests. So is this part of that?
Yes, great question. Yeah, you can get a lot of information from nephrectomized kidneys. I know there's a great resource in the PKD RRC with University of Kansas, where they have a lot of the samples there, and it's been very valuable to the community. We're personally working on trying to get some of these kidneys on our site, and then looking at some biomarkers as well. The idea is, it's going to be a collaborative effort, right? So not one place can do everything together. The best way is to have many of these repositories that we can cross-talk between the clinical data, imaging data, which is super easy to share back and forth after you de-identify. And then if there's a biomarker of interest for a certain group, and then you can just easily test the hypothesis there. In terms of, in general, kidneys that are already have failed, usually they're not of highest value, but they usually have a lot of information. But I think kidneys that have not reached kidney failure that's hard to get our hands on these samples because we
yeah,
don't do
if I-
nephrectomy for.
Yeah, but some of us do what's so-called preemptive nephrectomy. So depends how you define kidney failure. So in theory, people like myself could have waited. We went because we went with live donors right away the minute the insurance allows it. So you have the difference between GFR of 20 to GFR of maybe 10, and some people survive to there. So is that any use? Because again, maybe organizing all the transplant centers and getting those to connect.
Yeah, absolutely. Yeah, I agree with you.
And the second part of the question is related to the imaging. Are you working? I happen to not being just a patient, I'm also a scientist myself in data science and machine learning and all of that. And I know that there are several companies, some more established, some even startups, who already do a lot of work so-called under triage. For example, for cardiology, where they actually on the spot helping physicians to diagnose stuff based on the humongous amount of cardiology images they already seen, either MRI or CT or even combining now with additional. So is this something when you refer to the machine learning, are you working with companies, not just within the research center themselves, but companies who actually already possibly dealing with this kind of work, maybe not necessarily for kidneys? I happen to know myself about one or two, and I was eager to ask them whether they would look into doing it for something like kidneys.
Yeah, I'm not working personally with outside companies, but I know that there are several PKD groups who are trying to either cater for clinical trials, but also to clinical practice, because despite TKV being now a well-established prognostic biomarker, it's not easy to get. Even in big academic institutions, it's hard to convince the radiologist to give it to the nephrologist. So that's where our solution is one that kind of stemmed from that need. But there's other companies who are working on that to try to facilitate obtaining these TKVs to physicians. For us, I think, in addition to providing TKV, I think we need to start looking into more advanced biomarkers and then kind of putting all the pieces of the puzzle together.
Yeah,
and as
especially
more
when
help
you mentioned,
is great.
Yeah,
Right.
when you mentioned structure and all of that, that's why I was trying to think about going to it from the other direction, where if I know about a company who does this, after they have analyzed humongous amount of images, in this case for cardiology, working several centers, and now they're actually in real time in several hospitals doing triage. And I'm thinking you go from the other side and talk to those companies. Is there value in talking to them and say, would you leverage some of your technology now, work with centers like Mayo to try to use that for indeed helping diagnosis and projection for kidneys? Is that making sense?
Right. We're always happy to collaborate so we can advance the field, of course.
Yeah,
Thank you for
okay.
your help.
Yeah,
So
I don't want to hug everything, but just one last thing about biomarkers, since we find more and more in various areas how much inflammation is important. So, and I don't think, at least from my experience, anybody even looked at that as trying to follow up how I was with other inflammatory, whether markers or issues within my body. And is this something we are trying to understand better?
Yeah, I mean, inflammation, and so mentioned the urinary inflammatory biomarkers. It's hard to, well, so anything that's coming from the urine, that would be great. Anything that's coming from the serum would be great. I don't think a biomarker would be coming from a cyst fluid or actual kidney, because that's hard to do that in clinical practice. But inflammation is definitely one component, inflammation/fibrosis, one component where I see a patient who has same Mayo Imaging class and even same cyst characteristics, but then their GFR has declined so fast and I can't explain it. I can't biopsy them. There are other kidney potential kidney processes are not there. So it's usually could be an inflammation, could be more fibrosis. right? So, and then in the future, hopefully we'll have more treatments that are, we can say, okay, based on these biomarkers, we're going to treat you with A, B, and C treatments and not D, E, F treatments. One of them could be targeted to inflammation and fibrosis, for example.
Thank you so much.
I have time for one last question. Rebecca?
Thank you for this presentation. I'm curious about the cyst burden analysis that you mentioned. We've been trying, I'm from the University of Kansas, we've been trying to do some cyst burden analysis for some time. And one of the challenges that we've been coming up against is that not all cysts appear with the same intensity, homogeneity on the images. And I'm curious how well your automated approach handles cysts with different intensities. Thanks.
Excellent question. Yeah, absolutely. That kind of goes with the texture analysis in a way. So we've talked actually recently about this internally, because a lot of times we had a smaller cohort for patients who reached kidney failure before age 40. And then a common theme was that they had a lot of cyst bleeding, but it's hard to kind of really objectively track that. We've seen on their images, for example, they had a lot of hemorrhagic cysts. So that comes to your kind of observation that these patients had different kind of intensity, homogeneity. Probably they've bled more, they have more proteinaceous material inside of these cysts, and probably these patients would decline kidney function faster. So one way to extract it is through texture analysis, and happy to connect the dots with you as well if you have a large, if you have a cohort, and we're happy to kind of work with you on that. So hopefully we can, through texture, kind of look into the specific question, saying this, not all cyst intensity are the same. Yeah.
Thanks. We'd be happy to collaborate.
Absolutely.
Looking forward to it.
All right, on that note, I want to thank you again for a wonderful presentation. And please reach out to us at the PKD RRC if there's anything we can do to help. We greatly appreciate you taking the time. So thank you again.
Thank you, everyone.